I'm Dr. Maury Markman from City Hope, and in this week's segment of Minutes with Markman, I would like to continue the discussion I began last week on the evolution of cancer care from the focused efforts of the individual practitioner to the critical relevance of the oncologic team. To be clear, just as in the case I described last week, the individual physician has always had help. Obviously, in the operating room, surgeons had scrub nurses, etc. There were always radiation oncology technicians, physicists, and of course, medical oncologists would have nurses, infusion nurses, pharmacists, etc. But the primary decision maker, which is what I'm referring to, was that individual physician in charge. There's no easier way to acknowledge the change in oncology over the last several decades than to focus on the sequential delivery of standard of care cancer management, beginning with the, you might say, the modern cancer era, the 1950s, the 1960s, the 1970s. And I'm here specifically here focusing on solid tumor oncology, which of course is the vast majority of cancer care. In most cases, care began with the individual surgeon who would make the decisions about taking out the cancer, if it could be taken out, not be taken out, make decisions about the recommended surgery. It was the surgeon with the patients and their family, and often it was the surgeons deciding everything, but the key point is it was that individual physician who was the decision maker for the care. When the surgeon was finished with what he or she, and most of the time in that era, of course, it was he, could do, either finish the surgery or, in fact, the decision was made that surgery wasn't an option. The next doctor in line, often the radiation oncologist, became involved, and that individual then would make decisions about treating residual cancer, or maybe in the tumor bed because of the concern of residual disease. The radiation oncologist would make the decision of the next option and would be the one to interact with the patients and their family. And in fact, in those days, medical oncologists were not really involved at all at that point, unless, of course, the cancer sometime later recurred or there was metastatic disease, a diagnosis. Even when adjuvant therapy became a thing, for example, in breast cancer, the medical oncologist would only be brought to the scene after the surgeon had finished their care, his or her care, and the radiation oncologists were involved. Oh, now you can see the medical oncologist who will potentially give you some additional therapy, but that will be up to that doctor after the local therapy had been completed. Consider now how the standard of care today has dramatically changed in a number of settings, increasing number of settings in oncology. Initial management, literally initial management, even from the time of diagnosis, may very well be discussed by a group of specialists. Radiation therapy or chemotherapy may actually even be given prior to the conduct of an attempt at surgical curative therapy. Surgery may be done in the middle of a chemotherapy option, such as in a neoadjuvant approach. In fact, there may be a plan for surgery to be done later, after the completion of surgery and radiation therapy, and surgeons and interventional radiologists may in fact be intimately involved in the actual care, not from the perspective of their procedures to cure or palliate the patient, but to obtain critically important samples for molecular analysis in the laboratory. The point I'm making here is that there is very regular, ongoing discussions by critical members of the team to optimize therapeutic outcomes. Each member of the team has something to add to management, and optimal care is increasingly not the domain of a single specialty. And I will add, this team concept in the management of malignant disease continues to evolve. More on this topic in the final segment focused on the individual versus the team. In the next segment, on Minutes with Markman, and I thank you for your attention.